Good morning or good evening. I guess good evening for me and good morning for many of the folks who are on this call. Today I'll talk to you about definitive radiation therapy for bladder cancer. This is the outline of the talk. We'll talk about the overview of contouring, including the workup that you may consider for your patients. Next, we'll talk about choosing radiotherapy fractionation and use of continuous versus split course radiation therapy. And then we'll talk about some practical tips and contouring examples. So first, as an overview, this figure presents some of the staging for bladder cancer. The key components on this figure, so the white here is the bladder, or the lumen of the bladder. The green is kind of the lamina propria, or the first layer of the bladder, and the yellow is the muscularis propria, and these represent either T1 or T2 disease. So when people talk about muscle invasive bladder cancer, they talk about T2 disease, and that's highlighted here in yellow. In both the 7th and the 8th edition, T2N0 disease is stage 2, and if you have T3 or T4 disease, you can have stage 3 or sometimes stage 4 disease. The important consideration between the 7th and the 8th edition, the 8th edition just came out in 2018. The important consideration was that previously node positive disease had been considered stage 4, and it is now considered stage 3 disease. On radiology, this is what some of the scans may look like, and maybe some of the things that you're evaluating. It's very difficult to evaluate on a CT whether someone has T2 or T3 disease. Sometimes you can see frank extension through the wall of the bladder, but that is usually rare. It's oftentimes hard to just see where the disease is within the bladder, so just seeing T2 disease. And I've highlighted some of the lymph node stations here where you may look for enlarged lymph nodes, although these are also sometimes difficult to evaluate. For comparison, I'm showing you two images, one of the female anatomy on the left side and the male anatomy on the right side. And here we're comparing some of the treatment options from a surgical perspective and a radiation therapy perspective. So when patients are considered for a cystectomy, you can see what is removed in the female anatomy on the left side. So importantly, the anterior vagina, the uterus, and the ovaries are removed during the surgery, and this is not routinely part of our radiotherapy volumes. And similarly, for a male, for a cystoprostatectomy that's routinely performed, in the context of radiation therapy, sometimes the prostate is included in the volume, and sometimes it's not included, and it's a little bit controversial, and we'll talk about that in just a little bit. So what is the workup for bladder cancer? Much of this comes from the NCCN guidelines. Typically, with respect to the history, you're asking patients about a history of bleeding, irritative voiding, pelvic pain. I would say that hematuria or bleeding is probably the most common symptom. And you can, of course, ask for a history of chronic UTIs, schistosoma exposure, et cetera, although this is a little bit less common. On the physical exam, you may want to consider an external genitalia exam, a rectal exam, and assessment of costovertebral angle tenderness. And these are all important if you're considering that there may be another cancer besides bladder cancer that may be involved. On labs and imaging, the most common workup includes urine cytology, a cystoscopy, and a TURBT with an exam under anesthesia. For patients with high-grade or muscle invasive disease, on blood work, we often check a CBC and CMP with ALK-Phos. And the ALK-Phos is important because if it's elevated, you may be concerned about bone metastases. So on imaging, typically what's ordered is a CT of the chest, abdomen, and pelvis, imaging of the upper tracts, that is up to the kidneys, and this can be done with a CT urogram, and a bone scan if the ALK-Phos is elevated. Oftentimes, these patients are seen in a urology office, and we work very closely with our colleagues in urology for a cystoscopy with mapping at the time of the TURBT. And so sometimes random biopsies are performed, and also targeted biopsies are performed of the lesion. And a urologist may often be able to provide a bladder map, that is, images of the bladder where they had areas of concern, where they saw what was definitely tumor, what may have been tumor, and areas that did not look like tumor. And if there's any concern for involvement of the trigone or the bladder neck, urethral biopsies may also be performed. For muscle invasive disease, there are typically two routes that patients may go down. They may go down the route of cystectomy, that is surgical therapy, or they may come for chemoradiotherapy or bladder preservation. So patients who are selected for bladder preservation with chemoradiotherapy should have all the following features. In general, they should have a unifocal T2 or T3 tumor, node negative and non-metastatic. I'll tell you that N1 disease is oftentimes considered, and sometimes we'll see patients with what looks like an enlarged lymph node, and we may still consider them for bladder preservation. We'll talk about that in the next few slides. These patients should be a candidate for a maximal TURBT, and this may sometimes exclude patients who have large tumors, a tumor in the diverticulum or at the bladder dome. Patients should not have extensive carcinoma in situ, which can suggest that the entire bladder is involved, and there's basically field cancerization, where you just don't know where the disease starts and ends, and it may be going into the ureters or lower into the urethra. Assessment of hydronephrosis is also important, so patients should not have hydronephrosis, particularly because one of the typical chemotherapy agents that's used is cisplatin, and cisplatin can worsen the hydronephrosis. If patients do have hydronephrosis, which you'll be able to tell on your CT of the abdomen, you may try to correct this with a stent or a percutaneous nephrostomy. And again, working with the urology team is critical here, because they will be able to help take care of the patients from this perspective. Patients should have a relatively good bladder function. And if you're considering a split course approach, which we'll talk about in the next few slides, they should be medically fit for cystectomy, because with a split course approach, cystectomy, or the possibility for a cystectomy, is part of the treatment paradigm. And finally, transitional cell carcinoma histology is preferred. That's the typical type of bladder cancer that we see. Next, let's talk about choosing radiotherapy fractionation and use of a continuous versus a split course approach. There are two common treatment paradigms for chemoradiotherapy. The first one is the split course approach. This is also from Mass General, or the Shipley protocol as it's sometimes called, and it has an induction chemoradiotherapy phase. There's a planned break with an assessment with a cystoscopy, and then a consolidation chemo-RT phase afterwards, or proceeding to cystectomy. The second most common approach is the continuous course approach, and this is just going through with chemo-RT from the beginning and not planning for a cysto in the middle. And I would say that as of 2021, which is when the meta-analysis of the BC 2001 and the BCON clinical trials was published, this is likely superior versus the split course approach for a few reasons. One of the reasons being that it had improved local control, particularly with hypofractionated radiation therapy. So for historical context, I just want to show you what the split course bladder preservation protocol looks like. So patients had a maximal TURBT. They went to the induction chemoradiotherapy phase. They then had a cystoscopic response. If there was a complete response, they would proceed with the remainder of their chemo-RT course. And if there was no CR, they would have a salvage cystectomy. And this is kind of the key difference between split course versus continuous course. And although this is an option, I would not recommend this regimen for a few reasons. Number one, with the new BC 2001 data and hypofractionation, which you'll see in a minute, the local control is better with hypofractionation versus conventional 2 gray fractions, which is what this is. Number two, this is logistically much more challenging. You have to coordinate with the urology team, and there are a lot of more moving parts, and it may be more difficult to schedule everything. And number three, from a radiation therapy perspective, most radiation oncologists would not want to do a split course of treatment because of accelerated repopulation. So this is the continuous course chemoradiotherapy protocol, and this is from BC 2001 from Dr. Nick James. And here, this protocol was a 2-by-2 randomization. So patients could have what was called the standard volume, or they could have a reduced high dose volume, meaning that they would have an SIB, basically treatment of a small portion of the bladder where the tumor was to a higher dose, and an elective lower dose to the remainder of the bladder. And I'll tell you more about this. The other randomization in this protocol was use of chemoradiotherapy versus radiotherapy alone. This is what the volumes on the protocol looked like. So in the standard volume RT arms, the entire bladder would receive 64 Gray in 32 fractions or 55 Gray in 20 fractions. One way to remember this is that in the UK and in Europe, the CHIP trial is popular for prostate cancer. The CHIP trial is also 20 fractions. So this is a UK-based trial, and similarly, it is 20 fractions. And the reduced high dose volume that you'll see here, so for patients who were on the reduced high dose volume arms, you would contour the bladder tumor, you would add a 1.5 centimeter margin, and you would treat this to 55 Gray and 20, and the remainder of the bladder would go to 44 Gray and 20 fractions. That's actually similar to what is used in CHIP if you're considering pelvic nodal radiation therapy. Or you could also go to 64 Gray and 32 fractions, and then 52 and 32 to the remainder of the bladder if you were on the conventional fractionation arm. So in the protocol, the way that this is written is that it delivers 80% of the maximum dose to the uninvolved bladder. And so if you take 80% of 55, that is 44. BC 2001 had relatively slow accrual to the reduced high dose volume versus the standard whole bladder radiation therapy arms. And I put this information in here. You can read it for reference of exactly what they were assessing. They were trying to see if the toxicity would be lower with the SIB approach, but they just didn't have enough patients to do the full analysis. And so this publication was put out in 2013, but it did not show any differences, but it was probably underpowered because it did not meet the accrual goals. The important findings of BC 2001 was that chemoradiotherapy had improved local regional control over radiotherapy alone. The overall survival was relatively similar, and you can see maybe the curves start to separate at 5+ years, but this was not statistically significant. There was also no change in late toxicity. The other important finding from BC 2001 and BCON, which is a separate trial, where a meta-analysis was performed of these two trials, was that hypofractionation, that is 55 Gray and 20 fractions, had improved local control versus conventional fractionation, or 64 Gray in 32 fractions. And so you can see that on the forest plot here. Even though BC 2001, I think, provides one of the standards of chemoradiotherapy for bladder preservation, there are other options. So for example, RTOG 0233, University of Michigan, and RTOG 0712 had different types of chemotherapy regimens that were used. So our next part is a Zoom poll, and this is just a question for the information that we just reviewed. Which radiotherapy fractionation regimen has the best local control rate in the treatment of T2N0 M0 bladder cancer?
Answers are pouring in. Let's give it. Are you able to see that?
Yes. All right. So about 54% of people said option B, which is the correct answer. So this is 55 Gray and 20 fractions to the whole bladder and coverage of any tumor extension. And so this was the hypofractionated arm of BC 2001, and it was compared to 64 gray and 32 fractions, which is option A. And so this had improved local control based on that meta-analysis. We put option D in here, which is 60 gray and 20 fractions, because this is a standard radiotherapy treatment option for prostate cancer, and that is from the CHIP protocol. So again, the UK uses 20 fractions, both for bladder and for prostate cancer. All right, our next question is, for a patient with T2N0M0 bladder cancer who will be treated with definitive chemoradiotherapy, how should the pelvic lymph nodes be managed? And the answers, or the potential answers, are that it is mandatory, it's discouraged, it's controversial, or that pelvic lymph node dissection is recommended, and then adjuvant pelvic nodal radiotherapy should be used if any nodes are involved.
All right. Poll is ended.
Okay.
Here are the results.
So the most common answer, about half of the responses, was that elective pelvic nodal radiotherapy is controversial. And so it's currently unknown how we should manage pelvic lymph nodes. It's actually somewhat similar to prostate cancer. And in the context of BC 2001, pelvic lymph nodes were not treated. It was just the bladder alone. However, I think that, now sometimes we'll see patients with what looks like an involved lymph node, and sometimes physicians will treat the pelvic lymph nodes to an elective dose, maybe something like 44 gray in 20 fractions. There's not a lot of clinical data behind this. We kind of extrapolate from other disease sites and what we think should be done. So it's certainly not mandatory, and it's not discouraged, but you could use it if you think that maybe the nodes were involved. In general, pelvic lymph node dissection is not recommended for node positive disease, and usually the surgeons will not operate on node positive disease. Okay, our final Zoom poll question. What was the major change in AJCC staging for bladder cancer from the 7th to the 8th edition? And so the options are that in the 7th edition, node positive disease was stage 4, in the 8th edition, it's stage 3. In the 7th edition, it was stage 3, and now it's stage 4. In the 7th edition, node positive disease was stage 4, and in the 8th edition, it's either stage 2 or 3, depending on your T stage. And in the 7th edition, it was stage 3, but in the current edition, it's either stage 3 or 4, depending on the T stage.
Okay, let's give another 10 seconds. All right.
Okay, so the answer to this was that it used to be stage 4 disease, but it is currently considered stage 3 disease. In the next part, we'll talk about some practical tips and contouring examples. For patients who you're considering for definitive chemoradiotherapy, when you ask patients to come for CT simulation, here are some of the instructions that you could consider. Patients should be supine. They should have their arms on their chest. So the reason for this is that if they have their arms near their pelvis, they will be present on the scan, which is not where you want them. Some sort of immobilization should be used. So the most common is something like a Vaclock bag. And you can also coordinate with the urologist to place fiducials at the time of TURBT. So sometimes when the urologists see these patients, number one, they can do a bladder mapping, they can do targeted and random biopsies, and they can place fiducials all at the same time. And so if you have a multidisciplinary clinic and you're working closely with your urologist and you're presenting these patients at tumor board, you can discuss all of these things up front, and the urologist will know exactly what you'll need from a radiotherapy perspective. For the scan region, typically we're scanning just the pelvis, so the bottom of L5, although if you think that maybe there's a lymph node that's near S1 or something, you could expand this superiorly. And we go to the lesser trochanter. I would use a standard slice thickness, which is around 3 millimeters. I usually don't use IV contrast. Oftentimes there is a prior diagnostic CT with contrast that is present, and that can be fused. And that will be a lot easier. And also if these patients have any renal insufficiency, you don't have to worry about any issues with IV contrast now. Similarly, PO contrast is probably not necessary, assuming that you can see the small bowel, which is one of your main organs at risk when you're contouring. The next set of instructions is for bladder filling. So I think there are two main options. Number one is to have an empty bladder, and this was the most common approach that was used in BC 2001. And if you're treating the full bladder to 55 gray and 20 fractions, this may be the easiest, it may be the most reproducible. The other consideration is to have a slightly and comfortably full yet reproducible bladder if you're doing a simultaneous integrated boost. So why would you consider this? What are the pros and the cons? So number one, if you're delivering 55 gray and 20 fractions, that's a relatively high dose to the small bowel, which is our main OAR that we would worry about in pelvic malignancies and other GI malignancies. And we typically would not accept that kind of dose to small bowel. And the same thing would hold true for bladder cancer. And so if you're doing an SIB approach and the tumor is in the inferior portion of the bladder, you can optimize your plan such that you're delivering the high dose, the 55 gray and 20 fractions to the tumor, but you're only delivering 44 gray and 20 fractions, which has an EQD2 of around 50 gray to the remainder of the bladder and to the adjacent small bowel. And that way you're not going above any dose constraints. The bladder filling will also push the small bowel out of the way. And that may just make it a little bit easier to deliver the treatment and meet your constraints. The challenge with this approach is that if it's too full, then the patient may not be able to reproduce the bladder every day. And if they're having some urinary symptoms, which oftentimes patients with bladder cancer have frequency and urgency, they may not be able to reproduce this bladder every day. And this problem may get worse over time as you're going through the 4 weeks of treatment while they have acute toxicity from radiation therapy. So there's kind of an art and a science to it. I try to do the second approach when I can, but if not, then I'll go with the first approach. Next, patients should have an empty rectum. If patients have a Foley catheter that's present, you can clamp the Foley for the CT sim and the treatment. And again, in this case, you'll have to clamp it around the same time so that they have about the same degree of bladder filling. This can worsen toxicity. And I don't think there's great long-term data on this, but sometimes there's no other option. And so sometimes we have to treat with the Foley in place, although I would say that most radiation oncologists would prefer not to. Finally, when you're creating your plan, you would review the bladder map from the urologist to create your GTV. And sometimes, especially in the world of Zoom that we have now, we can quickly Zoom with the other physician and show them our plan and just say, is this where you saw the tumor? Because this is what I think is the tumor, and this is what I want to treat with my high dose volume. The technique can be either 3D or IMRT. And if you're going to treat the pelvic lymph nodes, then I would use IMRT.
Dr. Zaorsky, if I can ask you a question. Do you generally use comfortably full bladder even when you're treating whole bladder, not doing a SIV?
I try to do the like slightly, moderately full bladder if I can. I wouldn't do like a very full bladder like sometimes, we have for prostate cancer, because then you'd be treating, the volume of treatment would be too large. But I try to use the second approach.
I see. Got it. Thank you.
All right. So this case is just a sample patient who has a relatively large tumor, and maybe the patient has difficulty with bladder filling. And here we're showing you what the contour and what the dose would look like. So the red is your GTV and the yellow is the bladder. And here you would contour the entire bladder, put a margin on for a PTV, and then treat the entire bladder to 55 gray and 20 fractions. And this was the most common volume in the fractionation regimen on BC 2001. Case 2 is maybe if you have a relatively small tumor that is near the inferior portion of the bladder, and the patient can maintain a comfortably full bladder. They know how full their bladder is, and you want to minimize dose to the small bowel. So in this case, and this is what I generally try to do, I would contour the GTV, put a 1.5 cm margin on the GTV. I would treat this to 55 gray and 20 fractions as an SIB. And then I would also contour the remainder of the bladder. And then put a PTV margin on this and then treat this to 44 gray and 20 fractions. So this was the other randomization of BC 2001 that did not accrue enough patients. Notably, I should say that the toxicity was similar between this case and if you treated like case one, but the low number of patients who were on the trial limited the evaluation. And so, I think it's up to you. If you think that you can do this safely and you want to try to minimize dose to the small bowel, I think it's a reasonable approach. The third case is for T2 node positive disease. There are limited data on definitive chemoradiotherapy for node positive disease, and this may progress rapidly. And some physicians will consider starting systemic therapy and then rechecking a CT to make sure that the disease is not blossoming outside of the pelvis. Because if the patient has progression, you would avoid definitive radiotherapy and maybe just use a palliative approach. But in this type of case, I would consider treating the entire bladder to 55 gray and 20 fractions, and then treating the pelvic lymph nodes, which are shown here, to 44 gray and 20 fractions. And this is similar to what the remainder of the bladder would receive with the SIB approach. And it's also similar to what prostate cancer patients on the CHIP protocol would receive. The pelvic lymph nodes, we'll talk about pelvic lymph nodes in one slide, but around this slide is where the inguinal lymph nodes start. So around here, and if you go inferiorly, you don't have to cover the inguinal lymph nodes.
We have another question, if that's okay. This is a question from Li Chia Ching, and she's asking if you use the hypofractionated 55 and 20 when given with concurrent chemoradiation.
Yes, exactly. Yeah, 55 and 20. These are images from a contouring atlas of the pelvic lymph nodes. So if you were considering treatment of the pelvic lymph nodes, you could refer to this atlas. The important thing from these images is that the external iliacs, which are here, they become the inguinal lymph nodes right around this line or at the top of the acetabulum or the femoral heads. So when you go inferior, like this slice here, these are inguinal vessels, and you would not need to treat these, but you can treat the external iliacs, the internal iliacs, the obturators, and the presacral lymph nodes, which are just anterior to S1 through S3. Okay, next, let's talk about some practical tips and contouring examples from the American Radium Society guidelines. And so these cases come from a group of clinicians who try to identify some of the most common cases that we see and some of the common issues. And one thing that you'll notice is that there can be a lot of discrepancy, and there are some areas of controversy, which we'll talk about momentarily. So the first case, and we should preface this by saying what treatment regimen is ideal for this patient. This is a 67-year-old patient who is a current smoker. He has a recent diagnosis of a 3-centimeter clinical T2 N0 M0 transitional carcinoma of the posterior wall of the bladder. He is medically fit for a radical cystectomy, but he wants to avoid cystectomy because of concerns regarding erectile dysfunction after surgery. And so the way that these tables and the voting for the guidelines works is that when the panel co-authors think that a treatment is usually appropriate, they will give a rating of 7 through 9. If they think that it may be appropriate, they will give a rating of 4 to 6. And if they think that it's usually not appropriate, they will give a rating of 1 to 3. And so that's what the group median rating here is. And if you see an X in the column that says disagree, that means that there was a heterogeneous response. So some people may have felt that it is appropriate or not appropriate. And so we preface that by putting the X here. So for this patient, you can see that most respondents said that external beam radiation therapy is appropriate. Split course radiation, it may be appropriate. The reason that people said that it probably wasn't is because this patient wants to avoid radical cystectomy. And so if they want to avoid surgery, there's probably no reason to do split course radiation therapy, because part of that is checking a cystoscopy And then if the cystoscopy doesn't show a good response, you would proceed to a cystectomy. But if this patient doesn't want surgery, then cystectomy is kind of out of the question. The other information that you'll see here, so concurrent cisplatin-based chemotherapy was very appropriate. This comes from BC 2001, as well as other trials. A maximal TURBT also people thought was very appropriate, and the use of IMRT or 3D may be appropriate for this patient. And the other thing that you'll notice is that elective pelvic nodal radiation therapy is controversial. So some people will say that it may be appropriate in select cases. The next variant is an 80-year-old female patient with COPD and coronary artery disease who has a 4-centimeter clinical T3N0M0 transitional cell carcinoma of the bladder dome, who was determined by the urology team to be medically unfit for radical cystectomy. And the other things that may tell you that this patient is probably not fit is the comorbidities. So this is the other part of our history and physical that is important to see how fit they would be for any type of surgery. In this example, you'll see that the panel members, again, rated external beam radiation therapy as likely appropriate. And they said that split course radiation is probably not necessary because cystectomy is also out of the question. So continuous course chemo-RT is probably your best option, similar to BC 2001. And again, using cisplatin-based chemotherapy is preferred if possible. Using a maximal TURBT is also preferred. And again, you can treat this patient with IMRT or 3D conformal radiation therapy. And again, elective pelvic nodal radiation therapy is controversial. The other point I should mention is that neoadjuvant chemotherapy is likely not needed with radiation therapy. So if you're planning on bladder preservation, you can just start with both chemotherapy and radiation therapy. All right, the next variant is a 67-year-old male who was a previous smoker. He had stage 3 chronic kidney disease and a diagnosis of a 3-centimeter clinical T2N0M0 transitional carcinoma of the right wall of the bladder. The key thing in this case that you may be thinking about is the stage 3 chronic kidney disease. And so the important difference for this patient is that if they have CKD, then cisplatin is probably not an option in terms of chemotherapy. You can consider 5-FU and mitomycin as per BC 2001 or gemcitabine and other types of chemotherapies that were mentioned in some of the previous slides. And I think this is the final case. So this is an 80-year-old woman with diabetes and hypertension, 6-centimeter clinical T3 transitional carcinoma of the left and posterior walls of the bladder, obstruction of the left ureteral orifice, resulting in left-sided hydronephrosis, but she has normal renal function. And so in this case, what this case is trying to test for is who is a good candidate for bladder preservation. And so patients who have hydronephrosis are generally not good candidates to begin with. And so you'd want to correct the hydronephrosis before you proceed with chemo-RT. And this can be done with a stent or a percutaneous nephrostomy. Some of the other factors that patients should ideally have are listed here. And so that's all the slides that we have. And I thank you again for inviting me